Today's topic, I'm going to talk a little bit about something that has come up when I've spoken to a bunch of people from a variety of different walks of life. They always ask me, why is it taking so long to cure Alzheimer's disease? So hopefully we'll cover a little bit of that during the lecture today. I also wanted to start by answering a question. The easiest question is always good to start on the right foot. Who is the speaker? That's me. I'm new here, so I'd like to introduce myself. I'm doing the clinical fellowship in behavioral neurology and neuropsychiatry here at the Brain Center. I started just in September, so I'm relatively new here. I completed my medical school at the University of Colorado, and I did my internship and residency at the University of Arizona, so you might see me around. I'm going to be doing a 2-year program here. I did a couple months in Cleveland and was made clear to program director that parts in Cleveland would only be done in the summer. So that was a key part of the fellowship, because they've had a rather cold winter in Cleveland, and you hear about it all summer when I was there. And what do I get to do as a clinical fellow? I get to see patients. I help out with the research department, and then I have started some of my own projects. So I get to do a lot of different things, and the best part of my job is I get to learn from a great group of doctors listed below, and APCs we have here, and as well as some of the great nurses that we have working here. So I'm very lucky to be here. So ground rules for today's talk, and there's only one, and that's if something doesn't make sense, please ask questions, but I understand because of the video feed we're going to do the questions at the end. So we can do the questions at the end, but please, if something doesn't make sense, absolutely ask questions. I was always told that you couldn't have a PowerPoint presentation without a Far Side joke in it, and this one is all the way back from 1986, and I still love this cartoon. Mr. Osborne may be excused, my brain is full, and incidentally, this is how I've ended every conversation I've ever had with Dr. Walsh, who's our movement specialist here. So I think we should start by talking about why this is important, why it is important to find better cures for Alzheimer's disease. And the thing about Alzheimer's disease is that it's a disease that is affecting a lot of people worldwide right now. 45.5 million people are afflicted with dementia. So dementia is a description of the end stage of Alzheimer's disease, which is an inability to care for your daily function, relying on other people to help get things done or during your day-to-day activity. So there's a lot of people living with dementia worldwide, and most of the cases of dementia are caused by Alzheimer's disease. But as people grow, as the global population is getting older, we're going to see a rapid expansion of the amount of people that are going to be living with dementia and Alzheimer's. And by the year 2050, which is not that far into the future, there's going to be over 150 million people living with dementia, of which most will be Alzheimer's type. So that means by 2050, 1 in 85 people will have dementia. And it is estimated that 40% of these people will require some sort of intensive and expensive medical care. And that's going to be a big problem for the economy and healthcare delivery systems across the globe. As you can see, that Alzheimer's disease currently costs global economies 1% of their total GDPs currently. So that's not taking into account this rapid expansion that is predicted to occur in the next 30 years. So it's important, and we can see that most of the new cases of dementia are going to occur in sort of the developing world, in China, in India, in Africa, and other places. So this is a crucial goal for not only the US, but the rest of the world, and not just in terms of medical care, but also economic care as well. So this is an important topic. So when I was thinking about the answer to this question, why is it taking so long to finding cures for Alzheimer's disease, I thought there were 3 things that was kind of stuck in my mind as to why it's taking so long. And these are my own theories. but I think they hold some relevance, and I think thinking about this as sort of a targeted overview of Alzheimer's disease is a good way to approach the talk. So I'm going to go over 3 different things why I think it's taking so long to cure Alzheimer's disease. The first is the concept of Alzheimer's disease as a new disease. We'll get into that. Developing drugs for Alzheimer's disease is complicated, and we'll briefly kind of go over why that's the case. And then testing drugs for Alzheimer's disease is extremely difficult, and we'll also go over that as well. So part 1, Alzheimer's disease as a new disease. So this is kind of my own idea. So, but I think it gives a nice historical background of Alzheimer's disease. So if we look through literature going back to 2000 BC, ancient Egyptians documented that old age could be accompanied by a memory disorder. So this concept that age is associated with problems with memory is not necessarily a new idea. And then Solon, the father of legal thought, I think he wrote, it sounds like this could be part of the first ever country western song. He wrote that judgment can be impaired by physical pain, violence, drugs, old age, or the persuasion of a woman. So this is a concept that goes back to Greek and Roman times. And the term dementia is traced all the way back to the 14th century. So it's just a concept that we've had for a long time. But for a long time, dementia was thought to be part of normal aging. And we just accepted people that had the symptoms of Alzheimer's disease as having just a process of normal aging. And that was the case until 1901, when Dr. Alzheimer met this patient. Her name was August Dietmar, and she was a patient. Well, he was actually a trained psychiatrist, and he was working at a insane asylum in Frankfurt, and he also had an interest in neuropathology, and he was very good at making descriptions of his patients. So he would take these precise descriptions of the symptoms that his patients were experiencing, because back in 1901 there weren't treatments for the diseases that he was seeing, so schizophrenia, sort of bipolar disorder, some of the complications of some of the medical diseases we see now that we don't see now as much as they did back in 1901. And he was fascinated by Miss Dietmar because she also had, in addition to having symptoms that we'd see in schizophrenia and delirium, which were hallucinations and delirium and those kinds of symptoms, she also had a short-term memory loss. So he was very fascinated by this patient, and he thought about her a lot and wrote about her a lot in his own journal and things. But then he eventually got picked to move to Munich and work in a super lab, so kind of an NIH at the time. So a bunch of famous doctors had got together, and they formed a lab in Munich, Germany, and they were doing a lot of studies on the brain, so neuropathological studies, looking at people's brains, and they made a lot of advances, things that we're still using today. So he joined this super lab, but he kind of kept his mind on thinking about this patient, August. And then she died in 1905, and he actually arranged to have her brain be brought to Munich, where he could study it. And she was only 51 at the time, so she was much younger than patients that typically had memory loss. So this was a fascinating case for him. And along with some colleagues who used some staining techniques of the brain, he found some interesting things in her brain. And one of those was this neurofibrillary tangle that you see. It's quite obvious in that slice on the third picture on that screen. And also, she was noted to have some plaques, so some holes in her brain. So he was very interested in this. And in 1906, he published the first paper documenting his findings. It was a short paper, but it was the first time that the clinical symptoms of memory loss were correlated with the pathological findings. So this was a major breakthrough in the concept of Alzheimer's disease. And then in 1910, a famous, well, probably father of psychiatry, Dr. Kraepelin, he published his first book, a textbook on psychiatry. And in this textbook, he named the disease Alzheimer's disease, and the disease has stuck till now. So this was a sort of a fortuitous relationship between the Dr. Alzheimer and his patient. Dr. Alzheimer only lived to be 51, and he died shortly after the publishing of that textbook paper, but he made important contributions to the field of neuroscience, in addition to giving his name to Alzheimer's disease. And then surprisingly, so this publication came out in 1906, and then almost 60 years passed without much advancement in the field of Alzheimer's disease. It was just, again, kind of taken as a fact that memory loss kind of happens when people get old, and it was just something that wasn't worthy of rigorous medical study. For example, in 1975, there were only 42 papers published on Alzheimer's disease. So that's not that long ago, and that's not very many papers. And then things changed in 1977. A consensus conference concluded that the clinical and pathological features of early Alzheimer's disease and late memory changes were probably the same disease, and this sort of fostered a new era of Alzheimer's interest in research. And there's been an explosion for the past 40 years in what we know about Alzheimer's disease. And in 2013, with the same search criteria, there were more than 7,000 papers. So there's been a great interest in advancement in Alzheimer's disease, but there was almost 60 years of not much research. So this is sort of a new idea. This concept of Alzheimer's disease is not really been around that long in sort of the contemporary medical research community. So it is kind of a newer disease. So that's kind of my part one. That's a little bit of the overview of the history of Alzheimer's disease. I think that sort of gives us a sense of maybe why we're sort of just now developing new targets and new drugs. I think the second part, and the other important thing to realize about developing Alzheimer's disease drugs, is that it's complicated. It's certainly difficult to find drugs that will combat the process of Alzheimer's disease. And this is an illustration from a recent paper talking about the potential targets that you would attack in Alzheimer's disease. And you can see it's quite complicated with a number of arrows and circles, and it's a complex cellular concept of things that we have to target when we find Alzheimer's disease drugs. So we'll go a little bit into what causes Alzheimer's disease. So Dr. Alzheimer was not that far off when he looked at the brain of August and saw that these amyloid plaques were in her brain, and we do think that that's the most important factor of causing Alzheimer's disease. So amyloid is a protein, and it's highly conserved. So if you look back at the genes of our ancestors thousands of years ago, we were making amyloid back then. So it's not a new genetic aberration. So it's a gene that we've all had, and it comes from a protein called amyloid precursor protein. It's a protein that's found throughout every cell in our body, but it's highly expressed in nerve cells. So in our brains, the cells that are in our brains will produce a lot of amyloid. And we don't really know what the function of amyloid is, but it must be doing something important, otherwise all our cells wouldn't be producing it. But we don't really know. So even at this point, we don't really know what amyloid does. So in Alzheimer's disease, amyloid builds up in the brain. So we're all producing amyloid, but we all have people that don't have Alzheimer's disease have an ability to deal with the amount of amyloid that we produce. We clear it out of the cell, and it gets into our blood, and then our liver eats it up, chews it out, and it's gone. In the brain of a person with Alzheimer's disease, there's a buildup of amyloid. And amyloid is produced by the breakdown of this amyloid precursor protein by two important enzyme complexes, and those are demonstrated in the pictures. So you have those two scissors. So amyloid is stuck in the cell membrane, and along come these two enzyme complexes that cut it and then produce amyloid. And you can see in that third picture, if too much amyloid kind of sits around, kind of like if you pour too much sugar in your cup of coffee, it starts to precipitate, then it starts to clump. And then we get a plaque like that in the third picture. So in Alzheimer's disease, it's the buildup of these plaques that are composed of all this amyloid that we're not clearing out of the brain. So this is what amyloid looks like on slides of the brain. So it's these clumps of amyloid proteins. So and it's disruptive to how as you can see, how the normal brain functions. If you imagine, it's like almost like having a little bit of little strokes around your brain. So that's a target. And amyloid is important to how we understand Alzheimer's disease because there's two forms of Alzheimer's disease. There's sort of the early onset of Alzheimer's disease, which you think that August Dietmar had. And people with early onset Alzheimer's disease typically will have symptoms by the age of 65, will have dementia by the age of 65. And the reason for that is that in early Alzheimer's disease, a genetic problem causes a buildup of amyloid. So when we think about somebody that has Down syndrome, they will invariably get Alzheimer's disease. The chromosome that builds amyloid is on chromosome 21. So a person with Down syndrome has an extra chromosome for 21, so they're building more amyloid. So that's the reason why we think people with Down syndrome will get Alzheimer's disease at an early age. There's three other mutations that will also cause early onset Alzheimer's disease, and they all relate to this protein, this amyloid protein. So that's only 5% of cases. In late onset Alzheimer's disease, which is 95% of the cases we see in the world, it's due to a combination of factors. So it's due to both the buildup of protein and the inability to clear it out. And we think that there's a couple risk factors to why you lose this ability to clear out amyloid. The biggest one is age. That's non-modifiable, but there's some other modifiable risk factors, things you can do to reduce your risk of developing Alzheimer's disease. Diabetes, hyperlipidemia, so high cholesterol, smoking, heavy alcohol use, and then we think the metabolic syndrome, which is sort of having diabetes and having obesity and low physical activity also increases your risk of having Alzheimer's disease. So the first protein, so we have the buildup of amyloid is the first thing that happens in the brain. And that in itself is doesn't cause Alzheimer's disease, but it causes a cascade of things that ultimately lead to Alzheimer's disease. So the second thing that happens is you have all these amyloid proteins and they disrupt the normal cells in the brain. And what we're showing here in the picture, in the first picture, is a neuron. And when a neuron interacts with amyloid, amyloid causes some toxicity in the neuron, and the neuron itself will disintegrate, and it will shrivel up, and it will die. So it's the first step is the amyloid builds up, and then the amyloid interacts with other cells. So it's kind of a two-step process. As you can see in that second picture, that's kind of what happens when the neuron disintegrates and dies. So there's a two-step process in this, and then we're looking at another side of the brain. This one has both plaques and tangles. So this is called these are called tangles. Those are called neurofibrillary tangles made of tau. I know it's kind of complicated, but there's two steps. It's the amyloid buildup, and then the tau that gets disrupted by amyloid. And the difficult thing about Alzheimer's disease, but the thing that also gives us hope for combating Alzheimer's disease, is that these processes take decades to cause symptoms. So we think amyloid, that the major process of Alzheimer's disease is can go on for about 20 years before somebody manifests the symptoms. So it's a buildup of protein for 20 years, and then all of a sudden, amyloid is disrupting tau, and then all of a sudden we start to have symptoms. So the buildup of this protein is going on for much longer than the symptoms we see. So in these pictures, what we see in this first picture, here we see that amyloid builds up in certain parts of the brain. So it builds up first in the part of the brain that is involved in short-term memory, and then it kind of expands to incorporate other parts of the brain. So that's why we typically see short-term memory problems first in Alzheimer's disease. And in the second slide, well, actually, in the first slide, it shows that by the time somebody is experiencing symptoms of Alzheimer's disease, how we typically think of Alzheimer's disease, having short-term memory problems, having difficulties operating household appliances, having difficulty shopping, paying bills and things, there's been already a lot of changes in the brain. And that's illustrated by those curves. So the blue curve is, you could essentially think of that as the amyloid curve, and that is going up first. And then we're seeing some of the other curves demonstrate other parts of the that we see after. So amyloid is the first thing that goes. So we're very interested in learning more about amyloid. The second graph is kind of a graph of symptoms. So we're seeing that patients are asymptomatic for a period of time, and then we'll go through a period of time where they're having mild memory problems we call mild cognitive impairment, and then finally we'll reach a stage of dementia. But as sort of this demonstrates is that we're seeing a lot of changes before we even see the symptoms. So, and this is just to give you a sense of what a brain with Alzheimer's disease looks like. And you can see in the second slide that there's been a lot of shrinkage. There's an expansion of the ventricles, which is the fluid-filled parts of the brain. And just a lot of shrinkage of the brain that we think is, a lot of this is occurring prior to the symptoms. The brain is pretty plastic. It can recover from a lot of changes, but at some point, at some threshold, we start to develop symptoms. So when we think about potential targets for Alzheimer's disease drugs, certainly the first thing that steps out is amyloid. And we want to stop that process before it does too much damage, or reverse that process. So we can target things like genes that produce amyloid. We can target inflammatory processes that we think also contribute to the buildup of amyloid. So there's a lot of targets out there. Tau is the other target, but that seems to be a later process. After amyloid has already done a lot of destruction, tau is another thing that we could potentially target. But I think there's a thought that by the time tau is being disrupted, there's already been a cascade of biochemical events that maybe is not reversible. And then we're certainly open to other ideas that we don't know about Alzheimer's disease. But the main thing is amyloid. So amyloid is large. It exists outside of the cells, and it seems to be the main player in Alzheimer's disease. So amyloid is really something that we're looking at going after. And I guess the question would be, there's amyloid in the brain, how do you get it out without hurting the rest of the brain? How about doing more damage than doing good by getting this amyloid out? And surgery is not the answer, unfortunately. But using the immune system is potentially an answer. The immune system could potentially recognize the amyloid almost like it was like a virus or a bacteria, and potentially could work to clear the amyloid from the brain. So that's a promising target. And we've actually developed a couple of vaccines against Alzheimer's disease. Back in 2005, there was a vaccine against Alzheimer's disease, and it made it all the way to phase 2 clinical trials. So drugs go through a bunch of different phases of drug design, and phase 2 is pretty far into a clinical trial program. So it got all the way to phase 2, but then what we're finding is that people that were given the vaccine started to develop an immune response to their own brain. Because essentially when you think about it, you're giving a vaccine, you're telling your brain, you're telling your body that you have an infection when you don't really, when the body isn't aware of it and it starts attacking itself. And that's what happened with the vaccine. About 400 people received the vaccine, and about 5% developed an autoimmune response to the vaccine. So a low percentage, but still a high number, an unsafe number. And it seemed to be pretty good at clearing the amyloid out of the brain, but it didn't help symptoms, unfortunately. So some good things about the vaccine, and potentially some things that could potentially be worked on, and maybe that could potentially be a helpful treatment for Alzheimer's disease. And there's at least one vaccine that's in development right now, and it went through a phase 1 trial successfully. So that's a promising target. So the problem with the vaccine was that your own body attacked itself. Potential other target would be to give the body its own antibodies to give them antibodies from what we've created in a lab and give them into a person, and then they would do the work of clearing the amyloid out. And that's a promising strategy for clearing amyloid. And there's been a number of trials with different compounds looking at how they would do in clearing out amyloid. And those are the names of some of them. And this is kind of a sense of how it would work. Basically, you would be given the infusion of the antibody. The antibody would circle around the brain and the body and would find amyloid attached to it, and then be cleared out of the brain and the body. So I think that's another strategy. That's called passive immunization strategy. So that's a promising target as well. So far to date, the studies have generally been disappointing. There's been some benefit in mild Alzheimer's disease with a compound called solanezumab. I put an extra U in there, unfortunately. That's not how you spell it. Take out the first U, and that's how you spell it. And it showed some benefit in mild Alzheimer's disease. So that's a drug that's going to be in development. It's actually an infusion. So you would have an infusion of this antibody into your blood vessels, and then it would hopefully clear out the amyloid. And there's other strategies for clearing amyloid, and those include blocking some of the enzymes that are involved in the production of amyloid. And those, unfortunately, haven't worked out so great so far, but they're being tested. And then potential other new strategies would be to block inflammatory pathways, to block tau accumulation, and then gene therapy, which is a little bit down the road. So that's kind of why it's hard to develop Alzheimer's disease drugs, because it's a complicated disease process. I think the third part, in my opinion, of why it's been so hard to find a cure is that testing these drugs is really difficult. For a clinical trial to be proven successful, you have to show that the drug that you provided a patient demonstrates a difference. So, the questions are, how long do you need to treat somebody, at what dose, and what measures? How do you measure that change in what the drug is doing? Do you use tests? Do you use reports from family members? Do you, it's a difficult thing to distinguish how to determine there's been a benefit. And the second difficulty about testing Alzheimer's disease drugs is that we don't really have good diagnoses for Alzheimer's disease yet. They're not 100%. And when you're enrolling thousands of people in clinical trials, how do you make sure that everyone has Alzheimer's disease and they don't have something that kind of looks like Alzheimer's disease but isn't caused by amyloid, it's caused by something else? If it's not Parkinson's disease, it's not these other dementias we see called frontotemporal dementia or vascular disease, those people are unlikely to have the amyloid. If you're giving them an anti-amyloid drug, it's unlikely that it's going to work. And it's always remarkable to me, but one of the large clinical trials testing a drug called bapinuzumab, so one of the antibody drug treatments, they tested those people to find out if they had Alzheimer's, if they had amyloid by an amyloid scan, which is an expensive new scan, so it's kind of a newer screening method, found that 30% of people in this trial didn't actually have Alzheimer's disease. And of course the trial failed, but that's because I think part of that is because 30% of the people didn't actually have Alzheimer's disease. So when you read about trial failures, it's always important to find out how were they making sure that people actually had Alzheimer's disease that were in the trial. So that's another added difficulty of testing these drugs. And I think a bigger question that the field is wrestling with: when do we test these drugs? When do we think that they'll be helpful for the symptoms? So we need to demonstrate improvement on symptoms, but at what point is it still feasible that you're going to see benefit? Because if we look at the picture of the brain, we see the difference between a healthy brain and a brain with severe Alzheimer's disease, and then you would think that people are having buildup of amyloid that are kind of in intermediate stages, maybe more prone to having a benefit. So there's a growing consensus that we need to treat Alzheimer's disease earlier. And the question is, there's some challenge. The question is, at what time and when is that feasible? Because it's a hard thing to ask somebody to be in an Alzheimer's disease prevention trial when you're not even sure you're going to get the drug. You think about it, you're giving an antibody that gets infused through a vein that's going to go into your brain, and it's going to potentially do things to your brain, and we're not even sure you're going to get Alzheimer's disease. So it's a hard sell, and you would think that the threshold for having side effects would have to be pretty low to convince people to be in prevention trials. And then also the second thing is, how do you demonstrate that you prevented a disease? How do we know that giving this drug is going to prevent somebody from having? We have an idea, but it's a challenge too. And the ways around that are finding people that are at risk, groups of families that have family members or other risks, using scans and other things that give us an idea that we think people have sort of the underlying amyloid buildup. And then also finding people with a genetic predisposition. So there's a couple different exciting prevention trials that are going on. And one of them is called the A4 study, and that's using the solanezumab antibody drug. And what they're going to do is they're going to screen people, or what they're doing, the trial is ongoing, is they're going to screen people with amyloid scans. So they give them a scan that we think picks up amyloid. It's not 100%, and it's certainly not 100% at sort of the early stages of the disease. But people will be screened based on their amyloids. If they have amyloid on their scan, but they don't have any symptoms, so they're in that sort of early phase of the disease, then they'll be enrolled in the trial and they'll get the medication. Another study that's going on is called the Tomorrow Study, and they're basically screening patients based on their genetic predisposition to certain genes that we think make them higher risk of having Alzheimer's disease, and then using a drug that may modify this aberrant genetic pathway. And it's actually an anti-diabetes medicine called pioglitazone. So that's a prevention trial. So for both of those trials, they're looking for patients that don't have symptoms at all. And then the third interesting prevention trial is actually called the Alzheimer's Prevention Initiative, and that's going to be that's ongoing in Colombia. And there's a certain family, a number of families that live in a certain part of Colombia that have one of those mutations that cause an increase in the amount of amyloid production. So they're going to try some of the anti-amyloid treatments in this family to see if that prevents the symptoms. So some exciting prevention trials that are ongoing that to be on the lookout for in terms of, I think these are going to be key in telling us if targeting amyloid is really the answer to prevent Alzheimer's disease. So kind of exciting things. And I think I'm getting close to the end here. And the big thing about Alzheimer's disease treatments is to have a global impact, we don't need to necessarily cure Alzheimer's, but we need to delay the onset of the disease or slow the symptoms. And delaying onset by 1 year would reduce the prevalence by 9 million, and delaying onset by 5 years would reduce the prevalence by 50%. So small changes in delaying the onset are going to have a big global impact. And I think the goal is really to make the brain span equal the lifespan, because that's really the hard thing about Alzheimer's disease is that a lot of people with Alzheimer's disease are still healthy otherwise, but have cognitive difficulties, and it's making the brain kind of catch up with the rest of the body. And it doesn't necessarily mean that we have to stop completely Alzheimer's disease, but just delay its onset. So those are kind of my ideas about Alzheimer's disease, how I think about it and why it's taking so long. And I think there's always a plug to what we can do about it as a community. And certainly, as you know, there's lots of people with Alzheimer's disease in Las Vegas and in the United States and in the world, and they certainly need more care than we can provide, than's currently being provided for them. So that was a plug to volunteer help in different ways. And support Alzheimer's disease research, because that's really, I think, important. And let your congressman and congressperson know about that it's an important research endeavor for the country to participate in, and there's always the sense that we want to cut spending, but I think spending on Alzheimer's disease research is something that will pay off in the long run. And I think it's something that we can find a cure. You know, there's targets out there. And then the last thing I would say would be consider participation in a clinical trial. So we have those 2 prevention trials, and 2 of them are actually going on here at the Brain Center. And those are we're always looking for people that are interested in Alzheimer's disease research and participating in helping us understand about this devastating disease. So I think that's it. So, any questions from here? Yes?
When you're giving the antibody drugs, why don't the patients have an immunological reaction to them? Because you're giving them a protein that they didn't already have.
Yeah.
Why don't they have a reaction?
That's a challenge. That certainly is a challenge. So they modify the antibody to make it as pure as possible to be not recognized by the body. But it's a process that's why it's taken so long to develop safe ones. So they do strip out all the different proteins. They build it on a special backbone that is not recognized by the body. But certainly that's certainly a risk. But it's not like you're taking antibodies from other people and giving them. These are modified antibodies made in a lab. But that's certainly a challenge, a barrier to safe treatments.
Why is there not more emphasis on research involving targeting the tau? The only one I'm aware of is Wisnik, and that's kind of been downplayed.
Yeah, so that's the difference between tau and amyloid. So tau is inside the cell, so it's causing disruption of the integrity of the cell. So it's smaller, it's within the cell. We think it's a later process in Alzheimer's disease. So amyloid has really taken a center stage for the past 20 years, but I think there's a shift toward finding tau treatments. It's just a matter of how do you get the tau out, or how do you repair the tau, because it's so small and it's so difficult to manipulate. We don't have a scan for tau. We're developing it like we do for amyloid. So so there's a lot of challenges to tau, but that's a really good target.
Do you have any information on the trial that is ongoing that is targeting tau?
There's none here for tau. So, I'm not sure. I'm not sure where they're going nationally in the tau studies. So.
Because the amyloid targeting drugs haven't worked.
They haven't. That's true.
They keep working on developing more, and we get to phase 3 and they bomb. The
Yeah.
anti-inflammatory trials haven't worked.
They haven't. The question I'm not ready to give up on amyloid yet, just because I think we have better, if you look at the evolution of how trials have gone over the past 20 years, they're much more sophisticated now. We have an amyloid scan, so we're increasing the amount of people in trials that have disrupted amyloid. So I'm a little bit more optimistic about amyloid than maybe you are, but I think that we're not ready to give up on amyloid yet. But that's an excellent point about there's a shift toward finding other treatments.
Sort of piggybacking on her question, I have just recently read that some scientists are thinking that memory lies not in the cells, but in the circuitry between the cells.
Yes.
So should we be looking at that circuitry as much as we are amyloid and tau?
That's a good question. It's a very good question, and I don't know the answer to that. I think we're starting to think that the brain is more like a computer than it is this individual cells, and that the way they talk to each other is much more important than what we're realizing now. So I think there's a lot of hope in thinking about the brain in sort of a circuit. And we do have some treatments to sort of manipulate some of that circuitry. They're new, they're developing, and we'll see how they electrical currents to change and magnetic currents to kind of interrupt those circuits. So that's a really good, excellent point to bring up. Is there questions from the remote sites? The watermelon? You have a question?
Nothing from Alpha, thank you.
Okay. Go ahead.
Are you familiar with the Amen Clinic?
No, I'm not.
Because he promotes doing brain scans. They charge about $4,000 for it, and then based on the results of that scan, they offer a variety of vitamins and minerals, non-pharmaceutical.
Yeah.
And so my question is then, is there anything that's non-pharmaceutical, something in the category of vitamins or minerals that can enhance that can enhance the brain, maybe not necessarily stop this process, but or actually if there is something that can stop this process at that level that you're aware of?
So a lot of data. Oh, I'm sorry. So the question is, are there things, non-pharmaceutical things that we can do to prevent the buildup of amyloid in the brain? And are there other alternative sort of treatments to what we're doing now in sort of pharmaceutical trials? And the answer is yes, and the UCLA has a center, and I think this is going to start to be more prevalent as we sort of learn more about Alzheimer's disease, these multimodal things, doing not just one thing. And UCLA has recently published a paper about people that have sort of mild memory complaints, don't have Alzheimer's disease, but they did treatments that involved taking an anti-inflammatory, taking a vitamin, taking supplements, doing meditation, doing exercise, and those people generally did better. The hard thing is hard to study which is the important thing and sort of picking out things, and we're not that good in medicine, because if you look at medicine, we try to isolate the one thing that is doing having the benefit, and we're just not there yet. But I think that's kind of where the field is going to go in the next 10 years, is that we're going to find it's not just one thing, it's a bunch of different things that you can do early on to prevent this buildup. But that's certainly a new emphasis. But I don't have things off the top of my head. Certainly there's observational studies that say that reducing your amount of inflammation will reduce the amount of amyloid that builds up. We just haven't studied it rigorously enough.
Are you aware of the relationship between, so is it how genetic is Alzheimer's?
How genetic is, that's a good question.
Family?
So the best way we've studied that is with twin studies. So we took twins and they studied both twins, and we think it's about 60% genes. It's not a specific gene, it's probably a combination of different genes, little genes that contribute to your overall risk. So I think it's about 60%, and then environmental factors are probably another 30 to 40%. we're still trying to find out what genes and to what extent they're contributing, but there is a strong family genetic component to Alzheimer's disease. And in the young onset of Alzheimer's disease, it's 100%. So if you have that gene, you get the disease. So go ahead.
Are there major studies going on in other countries?
So all of the studies these ones that I mentioned, they're international. So there's a lot of studies going on in Europe, in Australia. I'm not familiar so much about what's going on in Japan as well. I'm not sure. I know that Japan is certainly.
They live very long.
They do, and we're signing a lot of observational studies. So observational study is we watch people over time and what was different about them, and we're finding things like turmeric, which is a part of a diet in India. People have a less risk of developing dementia. Healthy, non-sort of inflammatory, like a Mediterranean diet has also been associated with reduced risk of dementia. So things that have less of the inflammatory component have certainly been studied in observational studies, but that's also a good point that we need to look at other things, just pharmaceuticals. So I'm going to repeat the question. Can you go with that?
My husband is part of this A4
Uh-huh.
here at Ruvo Center. We had the genetic testing done to identify the genomes.
Mm-hmm.
We each get a pair, one from each of our parents. My husband carries the 3 and the 4 genomes.
Mm-hmm.
And that will be passed down to my children. That's what.
Yeah. So that's not 100% though. It's not, when I'm talking about the early Alzheimer's, this is not the early Alzheimer's. This is the risk with all late onset Alzheimer's disease. So the question is, getting the genome, testing the allele, ApoE4 allele testing, and how does that increase your risk, and is that passed on? And we do think it substantially increases the risk. So that for me would be to say to prioritize things like healthy diet, exercise, doing all the things.
The way Dr. Cummings explained it to us, the 3 genome carries about a 50% chance. The 4 genome carries about a 90% chance. So since each of my children will have gotten one or the other of those genomes.
That's not my understanding. Is that it's so the question I think, and I don't want to.
More an explanation than a question.
Yeah. My question is, not everybody that has that allele is going to get Alzheimer's disease. They're just at an increased risk.
Right.
And that's why we don't do it.
Offset with whatever genome they got from me, which hopefully would be the 1 or the 2.
Right.
It would lessen their chances.
Right.
That's why my husband is participating in that.
He's an excellent candidate for that study, so I'm glad he's doing that. Question?
Is there any way that these studies can be done on monkeys?
Oh, that's a good question. So we do these studies in animals. So the question is, can we do these studies in animals, and how can that help us understand Alzheimer's disease? The problem with doing these studies in animal models is we're not good at recreating Alzheimer's disease in animals and mice, and so we can recreate some of it, but we're really recreating that early onset type of Alzheimer's disease. We're not recreating the one that 95% of the population gets that's caused by all these different things. So we're not really good at creating a model, but we certainly have tested these drugs in animal models, and they work in animal models. They wouldn't progress past sort of the preclinical phase if they didn't work. So in those models, we're actually doing it, and they're actually working. So it's just.
So in this family in Colombia.
Yes.
Is that a unique situation where there's, if it's big enough to be included in your presentation,
Yeah.
It sounds like it's substantial in some way.
The question is about the family in Colombia. I think it's just a densely populated group that has this genetic risk factor, and it's an isolated part of Colombia, so they haven't left. And there's been a lot of close relations that have kind of, the genome hasn't spread out from there. So it's a highly dense population of people that have the genetic risk factor. So it's easy to get patients that have this, because in the United States, people that have the genetic risk for the early onset are spread out in their families, and this is a densely packed population. But they have the same genetic mutation or the same genetic problem that we have in the rest of the country too.
So it looks the same, but there's nothing about the environment. It's not environmental.
It's not environmental. It's just their genes. Yes.
What is the diabetes connection with Alzheimer's, and why was pioglitazone a candidate rather than some other diabetes drug?
Okay, so this is a good question. So there's been some studies that the mitochondria. So the mitochondria is so the question is, why was pioglitazone included in the Tomorrow study? So there's been some data that suggests that there's a mitochondrial dysfunction as part of Alzheimer's disease. And mitochondria are cells that exist, are parts of cells that exist throughout the body. And we're finding that people that have a genetic mutation, sort of one of those contributors to Alzheimer's disease, have problems with the way their mitochondria functions, and pioglitazone could potentially improve that mitochondrial function. So the doses of pioglitazone are much lower than for diabetes, so it's not going to be used for the anti-diabetic effect. It'll be used for the mitochondrial effect. So the dose is a lot lower. So
is that the connection? Because diabetes puts you at greater risk
right.
for Alzheimer's.
Yes.
I know, I'm diabetic, my son's diabetic, you know.
Yeah.
But how and why?
So it's not necessarily diabetes, it's the gene that messes up the mitochondria. That's what we're studying for the Tomorrow study. So it's to get into the Tomorrow study, you have to give blood and find out that you have that genetic mutation to even be enrolled in the study. So it's not about diabetes at all. It's about this sort of offset that this medication has on the mitochondria. Yes?
My husband has no family history of Alzheimer's, and we have one son and 2 grandchildren. What would be the advantage of having them tested to see if they have risk factor?
So the question is, what are we doing what is the advantage of doing genetic testing for Alzheimer's disease? So the only way I think would be beneficial is if it would do anything different. Would it change the way you're going to live your life? Potentially, there's a chance that if you're more likely to exercise or not, take care of yourself so you don't develop hypertension, that you do a lot of different things about your risk, then you could potentially get the test, and otherwise I don't think there's an advantage. Like I said, not everybody that has that risk factor is going to get the disease. So unless you think it's going to cause them to go out and do a bunch of different things and live their life differently, potentially it could. There's been some studies in terms of how does that impact people's behaviors, and generally it doesn't change, and people generally don't want to know. So it's kind of better. It does. It causes more problems sometimes. So it's a double-edged sword. Yeah. Sure. Go ahead.
Can you tell the high levels of the amyloid in a blood test?
The question is, can they tell high levels of amyloid in a blood test? And no, we can't right now because all of the cells in our body produce amyloid. So when we look at the amyloid in the blood, we're looking at the contribution from the rest of our body, so it's not very helpful. So we're developing tests because that would be a lot easier than doing. The only way we can do it now is to look in the CSF fluid to do a spinal tap, and that's a process that not a lot of people want to go through. So we're working on ways to develop that, but we can't. Last question.
With the teenagers and the young people that are going through all these chemical products, let's put it that way, are they going to make themselves more prone to Alzheimer's and dementia?
So the question is, are exposure to certain chemicals and substances increasing your risk of Alzheimer's disease? I don't know the answer to that, and I don't know if it's been rigorously studied. I can imagine that it would, because we know that certain substances increase your risk of vascular disease, so certain things cause your blood vessels to spasm and things, so I don't think that's good for your blood vessels. Head trauma is a risk factor down the line for Alzheimer's disease, and we're starting to see that more and more. So but I don't know if that's been studied in itself, but I would say probably anything that causes the cells to be angry and upset and not function properly increases your risk for having these sort of aberrant processes happen in your brain. So
they may have to revise their thought about how many people will be in that direction.
That's true. That is a very good point.
And this marijuana is not helping that.
No, well, that's the other thing with we're seeing the growth in the developed world, and part of that is because people in Europe and people in Africa and people in Asia are getting exposed to a inflammatory diet that we have here. So that's, we think, is contributing also to the risk. Yeah. So that's a good point.
Thank you.
Thanks.
Ladies and gentlemen,